So our U.S. healthcare economy may be the fifth largest country, or it'll be in there somewhere. That just is not where we want to be. And, it's obviously driven by an aging of the population. There's increased technology. There's a variety of factors, but we need to get a lot more health for the amount of healthcare we deliver. And so I think that in terms of where value-based care, I'm optimistic that it will more than be a thing. I think it will likely be the thing.
Hello, everyone, and thank you for listening to another episode of our podcast. Today, I'm joined by Dr. Arshad Rahim, Chief Medical Officer and Senior Vice President, Population Health at Mount Sinai. Over 2 decades of healthcare experience has led Arshad to cultivate an impressive career that spans clinical medicine, quality improvement, and healthcare analytics. He's one of those really rare MD, MBAs, and even though he's very involved in healthcare transformation from the top down, he remains an actively practicing hospitalist at Mount Sinai Health. Arshad, thank you for chatting with me today. Before we dive into the episode, could you tell us a bit about yourself?
Sure. No, my pleasure. Probably the best way to describe myself is, if we break it out into thirds, there's a part of me that's a third service worker. And that's kind of what really brought me to want to be a physician and provide care. It was a real passion for primary care. Probably a third economist. I think my first love academically really was health economics. And then a third kind of innovative business builder. And I've kind of found in a very circuitous but fun manner, kind of, is my career path. But there's elements of all three in terms of where I've ultimately ended up.
Wow, there's so much to break down there. Maybe let's start with the first third, your career as a physician. Tell us a little bit about kind of that journey. I know you live in New York City now. What was the journey to get there?
So I grew up, I'll be honest, my father's a cardiologist, and maybe there was just some rebellion. So I'm like, no, I'm not going to do that. I'm going to do something totally different. So I was an economics major. I took 2 years of Japanese in college. I thought, I would do, something else, not clinical medicine, and actually found a group when I was an undergrad at Duke in North Carolina called the North Carolina Rural Health Coalition. And it just dealt with took a real holistic approach to addressing health needs in Eastern North Carolina. And I think just what I saw something there that I could just never forget. And it just kind of created a fire inside of me. I think I would go way back. I think even my grandfather, there's some activism. So there's always been kind of an activist element to this too, that we kind of see something wrong, you want to try to make it right. And nothing was more important or felt more meaningful than trying to improve people's health. And all the different ways that health is compromised, that became very clear to me. So I actually went to work for this organization after college, even after being an economics major, and said, okay, you know what? I think I want to actually go into clinical medicine, but I know I'm going to do something broader with it. And I didn't know what that was, but I just knew there was a there. And so ended up kind of choosing, a school and an opportunity where there was a big focus on primary care and really on the community and community health. And so it was at the University of North Carolina. So I really enjoyed that. And then I was trying to decide, how was I going to kind of bring this all together? I knew I wouldn't be necessarily like my classmates. At that point, most went on to residency. So I was actually in the match, then dropped out of the match and said, you know what, I'm going to go to business school for a year. And I found and it was really just to figure out, how do I put this together? What I'm interested in, which was really trying to impact and improve the healthcare delivery system. So, in some ways I take I love the clinical aspect of it. I think I partly can say I love it too, because like a lot of physicians, contrary to, I'm not doing it all the time. So I get to kind of choose when I do it. So I was on this weekend. So by the way, I also do primary care, have a small primary care practice, and then I have hospital medicine. It just happened the past 2 weekends I've been on each one of those. So it's been pretty busy the last couple of weeks, but that allows me, to stay clinical and really just connect with everything you're trying to do. It ultimately starts, should start and end with the patient, and staying clinically active allows me to do that.
That's a fascinating journey because I think when I've engaged with a lot of doctors that ultimately went into business, they started more clinically and then kind of had a later in life revelation maybe of or interested in business. You started in economics, became a doctor, did an MBA, and back, it sounds like there's some maybe interest or some joy in kind of vacillating between those different hats, all revolving around this common theme of service, of how you care ultimately for the patient and the community. Is that a fair?
Yeah, I think that is. I think I'm a huge believer in the power of merging disciplines, regardless of what it is. It could be physics and philosophy, which I've had friends do that. I think just bringing disciplines together, there's tremendous power kind of in that. For me, it was clinical medicine, change management, kind of core business principles, and probably a huge piece in pop health is, there is a major analytics component to it. When you're obviously when you're trying to manage X number of people, and in this case, we're working on almost 500,000.
Just kind of been trying to organize it in my brain. So kind of told us about education journey, ultimately completed economics, MD, MBA, and then you went first then into clinical practice. How did you ultimately become a chief medical officer and move more into the population health side?
Yeah. So my first job out of residency, I did a primary care residency, internal medicine. But I actually really had I kind of fell in love with sicker patients just from a day to day. So I actually developed an interest in the intensive care unit. So I thought I was going to go do a pulmonary critical care fellowship, but I first said, let me practice a little. And I actually at that point got a job as an ICU hospitalist in Chicago. And so I was working there. And kind of through that work, and also just actually happened to have some colleagues who were, as you described, later career and kind of looking for the next thing. One of them actually kind of got interested in a company called SG2, which was kind of it's now owned by Vizient, but it was kind of a company that competes in the same space as the advisory board back then. And kind of very interesting thought leadership, innovation, some analytics products. And it just seemed really intriguing and kind of fun. So I took that opportunity, kind of helped build that company. And I've kind of spent a little bit of my career working for different innovative companies. One I spent a bunch of time with is actually Healthgrades. And I kind of really helped kind of build that over the course of 5 years, and had some senior clinical leadership positions, which I think started to prepare me for kind of more CMO type roles. I just was interested in, kind of the strategy, the operations, kind of all of it. And essentially, I do think kind of, the new world of the CMO is doing that. It's not just pure administrative or checkbox. I think it's really about change transformation. And I think that's true whether it's on the private sector or in the not-for-profit sector, large health systems. So I worked and I would say my career also kind of at first focused on overall strategy. Then I went to, I think, really heavy quality improvement. And I was running a quality improvement and quality measurement practice in Healthgrades. And then with the value equation, with it being cost or outcomes, outcomes over cost. Then I said, okay, you know what? I want to get to the cost side, because the economist in me was like, okay, I think we can really do something here. And I will be frank, I think the Affordable Care Act really changed things. It really kind of opened up the market. I didn't see the health systems as the innovators when I first started to look at these roles in the mid-2000s. It wasn't as obvious for me, but it became very obvious in kind of as you got like 2012, 2013, there seemed to be a real momentum in health systems really looking to push kind of a population health or value-based care agenda. And a lot of that, I think, was due to where some of the reimbursement went. So hence, I kind of moved in that direction. And that ultimately, after working at a health plan, not a huge amount, but enough to really understand that side too. It was a 5-star health plan in the Midwest. Actually, then moved to Mount Sinai in 2016.
Yeah, well, that's a great segue kind of into the crux of our conversation, which is really healthcare innovation and healthcare disruption. And just like you alluded to, Arshad, we're kind of at this turning point that has been going on for a while. It really feels like since the Affordable Care Act, like you said, of 2009, we've been on this journey of starting to transform from a fee-for-service to a form of fee for value, right? Where we try to measure the outcome, we try to measure the value, and we try to avoid getting mired in this kind of service-oriented, give me a service, I'll pay your bill, and we'll move on. And so where are we in that journey? Like, where are we in the continuum? You've been following it and leading it at Sinai since 2016. How far along are we? Maybe let's start with the State of the Union.
No, it's a great question. I think the State of the Union is, we're kind of at a very important point. And I would say the honeymoon's over. You started 2012, 2013. We're about 10 years in. So initially it was hot buzzwords. Everyone was juiced. In general, it just makes total sense that this is where care should be provided. Now, like anything, it takes the way we've been delivering care, if you even want to say since the advent of Medicare, maybe even before, and especially since the advent of Medicare and the DRG system in the 80s, has been very fee for service. So to kind of flip that, healthcare change sometimes feels like, it's not a motorboat that you're speeding around. It's kind of like an oil tanker you're trying to move sometimes. So, yeah. So exactly. It takes a while. There's a tremendous process that goes into it. I think some have been more effective than others. I think that, what I've really seen, one thing in general is that the operational excellence has to be there. You can have all the best strategy, but if you do not have that operational excellence, this can fall apart very quickly. And what I mean is value-based care transformation. So, and I think there have been some winners and losers to date based on that. Now, what I would say is, at a basic level, I don't think we have a choice. U.S. currently spends about $4.4 trillion in healthcare. Office of the Actuary has come out, predicts about $7 trillion by the year 2030. So, and then on a $35 trillion GDP, we'll pass the 20%, of our total spend.
We're around 17, 18% now, right, of GDP? And
yeah, exactly. 20. And even, a much smaller number. That number grows, the GDP grows, but healthcare grows faster than that and gets us above 20%. And I still have to look up how many countries' GDP surpasses 7 trillion. So our U.S. healthcare economy may be the 5th largest country, or it'll be in there somewhere. And that just is not where we want to be. And, it's obviously driven by an aging of the population. There's increased technology. There's a variety of factors, but we need to get a lot more health for the amount of healthcare we deliver. And so I think that in terms of where value-based care, I'm optimistic that it will more than be a thing. I think it will likely be the thing, but I do think we're at a very critical point. And I sit on some national boards such as NACOS, America's Physician Groups, NACOS being National Association of ACO. So we're very actively discussing kind of the value-based care agenda, both sides of the aisle. How do they feel about it? What do they need? What are misunderstandings? What needs to happen? Most importantly, I believe in it because I think it's the right thing for patients. And I think it's the right thing for communities. But I will say that the honeymoon's over and you got to have a strategy, but you really need to, in a lot of ways, treat it like a business. Productivity, outcomes, efficiency in delivery.
Measurement.
Yeah, you can generate 15 million in savings, but how many millions did you have to spend to do that? All those things are, I think, much more acute than they've ever been.
And you talked about something, Arshad. You mentioned technology, and I've been in, digital health, healthcare technology, med tech for, going on 20 years now. And I feel, we always come and pitch to CMOs like you and tell them, our great technology is going to lower your cost and it's going to make everything better. And I think just back to that, equation of like, actually, how much of the growth in healthcare expenses, a percentage of GDP, is coming through the adoption of technology and relative to the actual savings or the ROI that's behind it. I mean, and there's no question some of it maybe was foundational technology that had to be implemented. Like we wouldn't have any measurement of the patient record if we didn't have EMRs. They've been very expensive and they've been largely supported by government investment through the Affordable Care Act and the meaningful use provisions. But what's your maybe take on technology? Is technology really helping, or is it actually driving up cost in terms of this overall journey of lowering the cost of care while improving the quality of outcomes and improving the execution of the healthcare systems?
Well, I first appreciate, as a very successful technology entrepreneur, your sensitivity to at least consider both aspects of it. Actually, it's interesting. I've been thinking about this lately, especially as workforce costs or have gone up and not kept up with revenues. I do think in general, technology will have to be part of the solution. It will need to be in, I think, building the kind of the care delivery pathway around it. And that's where the operations becomes, even more and more important. And I think there's been some opportunity there. I do think technology is a huge positive, and I really believe is a must do in the context of, of workforce optimization or workforce efficiency. Mm-hmm. That we're just not going to be able to hire the number of FTEs that we have in the past to do things. There will be pressure on it. I still think, there's plenty of jobs. There are going to be plenty of jobs in healthcare, but I think the marriage of technology with human capital will need to be stronger and stronger based on the reimbursement and cost dynamics.
I see that, and just through the narrow lens of what we're trying to do with handheld ultrasound, I can speak to the fact that we're trying to think about how does technology move away from being like this shared asset that is like a departmental asset to much more of a device that powers the clinician to operate at their full scope of practice, like almost as a cyborg, right? That they now have technology in their tools. In many ways, I think like the mobile technologies have empowered us as individuals. And again, maybe you can say that societal transformation has not been for the best, but the reality is, as an individual with a smartphone in your pocket, you're powerful, right? You've got an amazing camera with you. You've got access to all the information in the world there. You've got incredible computational power. So how can we create a similar context for a practitioner? Like, again, in the narrow world of handheld, like having, ultrasound in your pocket as an alternative to just palpating or using the stethoscope, which is just allowing you a very narrow lens into what's going on with the patient. I really like how you're framing that to say that technology and the human equation have to come together actually to unlock that cost. It's not about one replacing the other. It's actually some sort of convergence of the two. Is that a fair summary?
I think absolutely. And it's interesting, even though one that's considered relatively, everyone's supportive of, obviously, we're not just saying this because, but handheld ultrasound, being an ICU hospitalist and as a non-critical care, fully board certified, but being there and working as almost an intensivist extender, those type of things are mission critical, and we never have enough intensivists necessarily. So it's important for hospitalists to be able to get that skill, and it's so much more empowering, and be able to, appropriately stick a needle in somebody for the variety of reasons you would, and to do that with more visualization as opposed to totally blind is, the benefit is immeasurable. But what is interesting there is you still wonder, like, what number of, I think, for example, every hospitalist should have some comfort with using handheld ultrasound, but it's just necessarily hasn't been kind of, rolled out in that fashion. So, I mean, maybe there's, a training gap or something that humans could do to kind of further the leverage, a very usable and well-established technology. And you kind of see that, many ways across the board, and I think that will become a separator in organizations, that kind of ability, the ability to really make the technology work for you, and also at scale too.
I guess like to train and educate, I love that point, because I think that at some level we're a bit mired in kind of mid-20th century education. Like kind of, we think, doctors have to go to residency program. They'll spend a 3-week ultrasound course to learn how to use it. Listen, I have teenage children, they learn how to use very complex technologies extremely quickly, and they haven't been yet to med school. Yeah. And so I think that it's actually incumbent on us as the technology community to think about how do we treat clinicians as users of digital technology that can capture a lot more and actually integrate the education from this kind of very structured traditional classroom model to something that is much more in-app, right? That you're watching videos or having a real tutorial, and maybe the AI is also helping to guide you how to use it. Again, I think about handheld ultrasound as akin to how we've learned to use digital camera. Digital camera is also like a very complex thing, right? You remember when we had the DSLRs, you have to set the f-stop and the lens and the contrast, right? But now, like the iPhone, automatically AI detects the face, switches to portrait mode, accentuates the highlights, increases the contrast, right? So can technology do more of that? Lower the hurdle rate, so you don't need to spend 3 weeks before you pick up the thing for the first time. And that's not just ultrasound. I mean that any modality in healthcare. So I think that that's actually what we owe back to you as technologists, is to lower that hurdle rate, make it much easier, much more intuitive to use, also recognizing that your doctors, principally the ones you're transforming the care system for, are coming out of university now armed with a lot of digital aptitude, a lot of knowledge on how to use technology.
Yeah, I love the fact that you think you owe us that. And yeah, I kind of agree. It's, make it easier to use. Yeah, make it as easy as, Apple products. I think those type of, the usability of it, and probably in a lot of ways could go up, and it will only enhance kind of, the overall, I think, care delivery and ultimately, hopefully, patient outcomes, because there's still technology adoption in a wide variety of areas, I think is much less than it could be. But what you described could be very augmentative.
Even though, just again, in our narrow world, I think that a big limitator is still, or limiting factor is still reimbursement. If I think about like general practice, so like we sell a lot into rural medicine here in British Columbia. There's a lot of, it's a very big province, only 4 million people. And so these doctors operate at a very broad scope of practice. They're using it for line placement. They're using it for OB, for cardiac, pulmonary. But in an urban setting, your GP sees you for 10 minutes.
Yeah.
It's a little incredulous to them to spend the first 8 minutes talking about my sore throat, prescribing medication, and then to say, oh, I see we've got about 90 seconds, Ohad. Why don't you lie down on the bed? I'll do a whole body ultrasound scan and I'll see if I can diagnose any fibrosis in your liver, right?
Yeah.
Because there's no reimbursement for it, right? If they were really worried about anything with my liver, they would refer me to the gold standard, which is radiology, unless again there was a code for it. And like you're come from intensive care and primary care, right? So that like often handheld ultrasound wasn't the reason, like it wasn't the exam itself, like it was just part of what you're doing, and therefore it didn't have its own fee code. So in a value-based environment, it would add a lot of value, but in a fee-for-service
environment,
why would I invest in this thing if I can't even bill for it? Ultimately, who's billing is the cardiologist who's doing the full echo in the cath lab, as opposed to the GP who's doing a limited echo just to see what the ejection fraction is before they decide on the best referral pathway, right? So I think that's a challenge where we're, like you said, the honeymoon's over, but we're still in that transformation.
No, we still are. Absolutely.
Service. And that, I think, is also what's limiting some of the adoption of novel solutions that could be beneficial.
Yeah, it comes down to, especially in the United States, we've had an inverted pyramid. If we really have a strong primary care base and then have kind of, the expertise at the specialist level, there are parts of the country where it's essentially there is some primary care, but it's very specialist saturated. Now, what I still believe is that kind of the mantra of right care, right place, right time, we have a lot to do there. And it could happen even between the relationship between primary care and specialists, in that there's a lot more that could be done kind of in a frontline setting. And I kind of equate that more to primary care. And then kind of in the referral setting, there's a lot better kind of optimization of the cases that are sent there. I think right now, that really doesn't happen. Oftentimes people skip primary care and are just going straight to specialty care, and for really not really using the true skill set of specialists. I think there's plenty of volume for all of our specialists. I just think it's potentially different volume than what they see today. And I think that partly that's where technology could help. I think, part of it, and you bring it up, ultimately, whether we like it or not, if you want the answers to a lot of the solutions and problems in healthcare, follow the money. And if the money is not flowing in the right way for the solution, it will destroy whatever approach you're taking. So I think we do need to look very effectively at the reimbursement. And that's where, if CMS is going to really be a value-based payer, they're going to really maybe need to change some things. And I know they're trying to, and most things can only happen incrementally. But I think that will have to continue. I think the private payers will have to continue. The state-based payers will have to continue. And I think ultimately we need, we can't have the 4 and 5 and 6 to 1 specialist to PCP ratios of usage. For every 1 PCP visit, someone may see 5 specialists. That is just not the way to go. I think we could serve more people. I think we need to find a way to ensure that doesn't, excessively or really degrade at all kind of specialist income, because we will not get where we need to be kind of as a healthcare delivery system nationally if that happens. But, I think there are ways, and there have been, some plans put in place that actually do incentivize some of the right ways. Probably one of the bigger successes, at least from, my perspective and my interaction with a lot of orthopedic surgeons, has been in, kind of the bundles for joint hip replacement. And I think that actually has not been a financial drain for the folks that have really been able to execute on it. And that really kind of met all those different must-dos that we've just been talking about.
I remember at one point there was also going to be a bundled payment for cardiac cath procedures, which, would fall under, right, some of the early triage, like, again, give incentives for primary care or even nursing to the initial triage of, coronary artery disease, and then treat that as part of the overall bundle payment of the patient that gets a cardiac cath procedure. Yeah, that's an interesting perspective of, bundles maybe are a way to help streamline that more effectively. I know that at one point, CMS and the FDA actually had announced that for breakthrough devices, they were going to give like a limited CMS code, like a category 1 code for, I think, 2 years for inpatient and outpatient to try to stimulate, again, adoption of novel technologies, even before kind of the entire reimbursement pathway was streamlined. But if you had initial reimbursement out of the gate, it would start to build up a base of users who were trying to do this in areas that maybe CMS and the FDA deemed valuable. So certainly a lot to be done there. You've given us a fascinating perspective on the State of the Union. Maybe just to summarize what I heard. So kind of honeymoon is over. We're getting into real implementation now. A lot of it is ultimately going to be execution driven, data driven. We have to really look at the returns. Technology has to be focused on empowering the clinician. And it's going to be that marriage of technology and the human equation coming together to unlock more of the value, and ultimately looking at new reimbursement pathways to drive and stimulate behaviors that are in line with the value-based care, in line with the fact that primary care could serve as this very important quarterback to help streamline the appointments with specialists downstream. Is that inaccurate?
Yeah, no, I think that's a great summary. Probably the only thing we hadn't touched on, I might just add in the technology realm, is obviously the other major user is the consumer. One area, especially in population health, that I've spent a good amount of time on, whether it's even trying to ensure adequate reimbursement, is remote patient monitoring. I would say for chronic diseases, I do think that's here to stay. It makes a ton of sense. Just the ability to even get people to goal, if it happens in between clinic visits versus virtual daily touch points, is the speed of that is not even comparable. And then obviously, I've always believed in an empowered consumer. Is a better healthcare consumer likely going to be over time a healthier and happier patient? And I think the more that we can, get patients engaged in the appropriate aspects of their health and really support that. And I think remote patient monitoring, especially, we've had some good success with hypertension, and that have put a few thousand people through that program. I've seen it firsthand. And so I think the other aspect of it is, what technologies, and you kind of mentioned, the iPhone has tremendous capabilities in so many ways, or I'm sorry, any type of smartphone does. There are other kind of consumer-oriented technology that I think it's an interesting time, and there's more coming out.
Yeah, no, great segue maybe into kind of the last section of our discussion today is kind of where's all this going? And certainly in a more empowered patient is one direction. Maybe just to share my perspective on where this could go. Again, I always come back to ultrasound. It's like, so it's like the one thing I know, ultrasound today is still a tool that can only be operated by a licensed healthcare practitioner in terms of the intended use of what the FDA allows. And that's true of any imaging modality. But I think that using AI, maybe even on a non-image basis, right, where it doesn't produce an image, but the AI automatically analyzes the image, we can put it in the hands of patients.
Sure.
To monitor a condition. And of course, we have to narrow the scope. Like I think of what happened to ECG, for example. Like ECG is, kind of, you could do a 12-lead full diagnostic ECG. You could also miniaturize it for a very simple consumer-oriented solution that is more like a binary yes/no machine for with like a few mobile solutions for that. And I think that's where ultrasound could go. Like I could envision a world where you have like a simple, maybe flexible ultrasound patch that is now monitoring your congestive heart failure, for example.
Sure.
Looking at B lines, looking at interstitial lung fluid. So really interesting to see where we could take that and again, just the role of the vendor community. I think we have to keep working at miniaturizing and really thinking again of the patient as our future user, even if that's not allowed today according to the FDA, but we're going to get there as long as we can find the right use case and ensure the FDA that it's safe and effective to use.
Yeah, no, I think that's a great perspective. Yeah, and pulling, some of these technologies that have just, that required provider usage in order to operate. You bring that in, the hands, and I think you are a perfect one, with, single lead EKG that's now available, can be done through your smartphone and a little pad where you put your 2 fingers on is a perfect example of that.
Great. Well, you've stitched together a formidable perspective, bringing together economics and business, data, clinical acumen into your world as Chief Medical Officer at Mount Sinai. Maybe as we bring our conversation to a close, for our listeners, could you give us one snippet, maybe one insight of what would you recommend to your fellow healthcare leaders and innovators who are tuning into the podcast, and especially those that are focused on leveraging innovation or leveraging technology to improve population health?
Not the omniscient expert here. I'll just speak from my own experience. Very carefully, selecting your technology. I think also limit how many things you're focused on. And I think what happens is, and I could definitely say a lot of academic centers do this, and probably a lot, is we end up with science projects versus real businesses. And really kind of focusing, develop the operations, develop the finances, develop how you scale, because ultimately that's how you generate more impact. I think focus on a few, take it deep, and then move on to something else. I think there's so much, out there. I think there's a lot of excitement, but I think some level of just focus and commitment will actually lead you further in the long run. I think is probably just one major area of it.
Excellent words of wisdom for any healthcare innovator, more focus. And, especially in startups, you're kind of living in the art of the possible. Like every shiny object is pulling you, but to your point, maybe focus on where can you have the most impact and seeing it all the way through to think not just the technology, but the practical implications, the ROI, the value prop. How do you scale it? How do you make it real in a healthcare setting? That's extremely valuable. Arshad, this was a lot of fun. That's all we're going to have time to cover today. But before we sign out, if people want to keep up with you, they want to learn more about what you're doing, where should they go? Maybe your social media handles, or where can they follow you?
Yeah, if I'm not terribly present on social media, but best would be LinkedIn. Just find, I think it's Arshad. I had to have my middle name Khan in there, Arshad Khan Rahim, MD, and you'll be able to find me. And yeah, definitely welcome, connecting and, any further discussion. And yeah, this has been a lot of fun. I appreciate it.
Thanks again. And to all of our listeners, thank you for tuning in to another episode of our podcast. That's a wrap.